Thank you very much. I present to this August webinar in May our guest speaker, a renowned scholar and a member of CMDA or your Dr. Victor Makonjola, MBBS, MSc, Fellow West Africa College of Physician, MNIM. He's a senior lecturer at the Department of Psychiatric College of Medicine, University College of the University College Ibadan, and consultant to the University College Hospital Ibadan. He attended Loyola College Ibadan, graduating in the 1989 set as the best graduating student with distinction in 8 subjects. He graduated 23 years ago from the University of Ibadan Medical School and was a graduate member of the Student Representative Council of the same university. Between 1996 and 1997, he was a member of the Alexander Brown Hall football team and the University of Ibadan Medical Student Association football team. And in his time, they won series of competition, including the serial winner of the Provost Cup. He was in charge of the affairs of the Embassy Club University of Ibadan between 1993 and 1994 section. Was the best candidate in the West African College of Physicians Faculty of Psychiatry exam in April 2003 and has won many fellowships to attend international conferences and research projects. In addition to the management of difficult to treat patients with complex social critical problems in general psychiatry practice, he has additional interest and experience in managing patients with psychosis, with comorbid addictions to alcohol and drugs, as well as working on innovative ways of extending services to hard-to-reach or neglected population. He is a UNODC certified trainer on management of addiction and a member of the Nigerian Institute of Management. He is also a recipient of certificate of training in leadership and management in healthcare and online training program of the University of Seattle, Washington, United States of America. He has held several administrative posts in his department, such as the chief resident between the year 2006 and 2007, a residency training coordinator between the year 2012 and 2017, and very recently served as the deputy chairman, medical advisory committee in charge of clinical service of University College Hospital Ibadan between 2019 and 2021. He has served as the Secretary General of the National Body of the Medical and Dental Consultant Association of Nigeria in 2015, and Vice President 1 between 2019 and 2021. He is currently the immediate past president, Medical and Dental Consultant Association of Nigeria. He is a key advocate of deploying good leadership and management skills in repositioning the Nigeria healthcare system for excellent service delivery. He is actively involved in research as evidenced by over 40 articles in reputable learned journals. I present to you Dr. Victor Makonjola for a wonderful expose on our topic today this evening. Thank you very much.
Thank you very much, Doc, for your kind words. I wish I could have that 5 minutes to the presentation. Next time you ask me for profile, I'll make it a lot shorter than that. All right, good evening, brothers and sisters. It's a pleasure to be with you this evening, and I've been informed I have about 5 minutes thereabout so that we can have some questions after the session. So I will go right into the business. Looking at the topic that has been selected for me to discuss this evening: drug abuse, an emerging epidemic among Nigerian youth, and looking for strategies for curbing this menace. I'll be presenting along this outline. And we'll start with definition of what a drug is, or a psychoactive substance is itself, and is any chemical which, when taken into the body, alters the function of the body. Either physical function or psychological function are altered by that substance. That makes the substance a drug. We also need to define what we mean by drug abuse. And that is any substance or psychoactive drug, performance-enhancing drug, that is used for a non-therapeutic or non-medical reason. When the purpose of use of the drug has become not for treatment, not to eradicate a disease or to make the patient feel better medically, then we'll assume that that individual is abusing the drug. So a drug that is abused could have medical value, may also not have any medical value. So the fact that a drug has a medical value, such as benzodiazepines like Valium and the rest, does not exclude them from being abused when they are used for reasons other than the therapeutic benefit that comes from the use of such a drug. In the topic, I've picked some of the keywords. Epidemic is one of them. So we're looking at the definition of an epidemic as a widespread occurrence of a disorder, a disease in a community at a particular time, or a disorder occurring widely in a community at a particular time. The term emerging also, it's a major keyword in the topic we're dealing with. And emerging diseases or disorders are those that appear in a population for the first time, or that may have existed previously, but are rapidly increasing in incidence or geographic range. So based on these definitions, are we dealing with an emerging epidemic when it comes to drug abuse? The answer will be obvious after the next few slides. The World Drug Report is an annual report by the WHO stating the state, and you're in collaboration with the United Nations Office on Drugs and Crime, that's UNODC, stating the state of drug use globally, not just use, but also trafficking, cultivation, everything you need to know about drugs are usually contained in the World Drug Report. The report of 2021 shows that 209 individuals, 209 million people were using cannabis. The same report, the subsequent years, this will be 2023, 2024 report, shows that in 2022, 292 million people used drug in the past year. And out of these 292, 228 million used cannabis. So using cannabis as our index drug, being the most commonly abused illicit substance, we can see that there has been an increase from 209 to 228. Overall, there's an increase of about 20% over the past 10 years in substance use. The other important aspect of the report is usually about those who have developed drug use disorders. There are different types of drug use disorders, but cumulatively, about 40 million people had drug use disorders in 2021, while in 2022, we have about 64 million people now have been reported to have a drug use disorder. That is a significant increase over that period. We're talking about 3% increase over a 5-year period. And we know that one in 11 of these people with drug use disorders are able to access treatment. Access to treatment is also influenced by gender. Men are more likely to find treatment options compared to women. So for men, 1 in 7 had access to treatment, while for women, 1 in 18. Most of the treatment centers are usually not suitable for the use of females. One other fact from figures that have been coming out in the past 5 to 10 years is the fact that women are increasingly using drugs, coming close to what men also do in something that was previously an exclusive preserve of men. So on the average, 1 in 4 women is a drug user, compared to what used to be, where it is a rarity to find women using drugs. And in fact, when it comes to non-medical use of pharmaceutical opioids, women are using almost on an equal basis with men. That's 43% women. The other major issue with drug use globally now are those injecting drugs. And that is because of the strong association with infection with hepatitis B, hepatitis C, and HIV. They form the nidus from which infection of HIV and hepatitis C gets into the general community. So it's extremely important. They're a special group and they deserve special mention and also special attention. Now that's the global picture. To answer the question, are we experiencing an emerging epidemic? In Nigeria, we need to look at this study by Professor Gureji and co, done over a decade ago, published in 2007, and involved, it was a community survey in the Southwest, South-South, a little bit of Southeast as well as Northeast of Nigeria. And that put the prevalence of cannabis, still using cannabis as our index drug, or prevalence of cannabis at about 3%, that's 2.7% use at the time. I think that was a lifetime use of cannabis of 2.7%, a past year use of 0.4%. Now, the past year use of cannabis is now about 10.8%. So we can imagine the significant increase in the use of cannabis between 2007 thereabout and what we have in 2017, 2018. That is a massive increase in the use. And that, to an extent, answers the question, are we witnessing an epidemic, an emerging epidemic? Of course, the study by UNODC that I've just quoted also shows that Southwest Nigeria has one of the highest prevalence of drug use in Nigeria, Oyo and Lagos State in particular, where some of the hotspots. The 3 major hotspots were Oyo, Lagos, and Gombe. Gombe is in the northeast of Nigeria. So 2 of the hotspots are in the Southwest where we reside. Now, cannabis use increased from 2.7% to 10.8% in about a decade. But I think that is even not so correct now, looking at it. That would give us a 4-fold increase. But what I'm seeing now, if we're using past year prevalence and not lifetime, is almost about 30-fold increase in cannabis use between early 2000s, that's 2003 to 2006 when the survey was done, and between 2017 and 2018 when the UNODC did another community survey of substance use. That's almost about 30-fold increase in cannabis use. So are we dealing with an emerging epidemic? The resounding answer is yes. So I want to appreciate the team for the very thoughtful topic that was selected for us to discuss. Now, it's not only the prevalence of use, not the frequency of use that has increased, but also the potency of what is being used has also increased dramatically over the past 30 years thereabout. There's strong evidence that cannabis being used now have about 4 times the concentration of tetrahydrocannabinol or THC, which is the addictive substance and also the deleterious substance with regards to being neurotoxic in the brain. But it's also what gives the high that drives the dopamine production. The quantity that is in the current cannabis, even the organic cannabis, is about 4 times higher than what used to be in the cannabis of the 80s and 90s. The next few slides will just give examples of drugs that are commonly used, but the general categorization are into depressants, into stimulants, and hallucinogens, and these are the drugs that belong to each one of those groups. The poster boy for depressants will be alcohol, and then probably the benzodiazepines, and of course opioids. And then the stimulants, cocaine is the most commonly used in that group, but now closely followed by synthetic medications or drugs such as methamphetamine and amphetamines. They are more common. They are also getting into more common use in Nigeria. And then we have the hallucinogens, LSDs, ketamine, and the rest. There's also an emerging industry of psychedelics, as they are called, the LSD, ketamine group, also magic mushrooms, and the rest are also evolving into another industry entirely. Both pharmaceutical, tourism, and all that are going on in that, guys. We'll see in one of the few slides as we go. So next few slides, I'll just run through for you to see some of the pictures of these drugs. Other opioids apart from heroin, fentanyl is important for us to be aware of because it's the commonest cause of death from overdose from opioids, especially in the US. I'm not sure if it's commonly used in Nigeria or if it's, everywhere yet in Nigeria, but definitely some of our colleagues in anesthesia do have access to fentanyl. But in the US, is now the #1 cause of death from opioid overdose is fentanyl. And that is also the same for Canada. It's important because of the rift between US and Canada currently going on. And then pictures showing how heroin is being injected, use of Vicodin. Pentazocine is also an opioid used for post-op pain and some other painful conditions. Unfortunately, health workers like you and I are at increased risk of becoming dependent on pentazocine. We've had doctors and nurses coming down with pentazocine dependence, and with terrible complications, musculoskeletal, psychological complications from these. And of course, unfortunately, deaths have resulted from these complications. So it's important that we're aware of this. We also have codeine, initially mainly common in the northern part of the country, also mostly a women thing, but now more mainstream, both in terms of geographic spread and also the gender involved in the use of codeine. Tramadol, I think there's information that 90% of tramadol seized globally were in Africa, West Africa, more importantly, and I'm sure Nigeria will feature strongly in that data. And usually the tramadol that are meant to be abused are not in 50 milligrams or 100 milligram capsules. They're usually in 500, 550, 1000 milligram capsules or tablets, usually produced by underground pharmacies in Asia and brought to the country. Day trip drug Rohypnol is important for us to know because it's commonly used to induce a bit of somnolence and drowsiness in ladies on a date, and then men do take advantage of such people, which is one of the reasons it's called the blue pill. The pharmaceutical companies colored it, made it blue, so that if it is dropped in a spirit, the spirit becomes colored, and you would know that your drink has been spiked, just to reduce the possibility of it being used in that guise. But we also know that from personal experience that young men also use Rohypnol. So not even when they're not planning to rape anybody, but they use it for themselves to step down when they take a stimulant. Following the use of cocaine or any other drug that gives a very strong high that makes you feel like I'm going to run mad if I don't do something, Rohypnol comes in handy to step down that highness, so to say, in quote, and makes you calm and set it. So most young men in university use it for this purpose rather than to achieve rape. Street names are extremely important so that conversations around you can easily pick up when young people are trying to get involved, either to start or they're already in it. Cannabis, common names now include SK, Arizona, Colorado. Loud is probably the most commonly used brand of cannabis. It's about 1,000 naira per wrap, and you can imagine what that would do to the finances of a student. Colorado, more commonly associated with psychosis, at least anecdotal evidence from our wards. Most people who come down with psychosis tend to use the Colorado species of cannabis. And then we have squishes, which is a mixture of almost everything you can imagine in spirit. So why do people initiate drug use? Main reason people use drug is in pursuit of pleasure. And it's never really, it's not usually that they design to wreck their lives or, make trouble for their parents, but they just wanted pleasure. But there are also other reasons. Sometimes drugs are a way to relieve pain, either physical pain or emotional pain. When somebody gets jilted, a young person, the pain of being jilted feels so heavy and unbearable that if the wrong crowd are around you and they introduce you to drinking or to smoking at that point, that may be the beginning of a lifelong problem with drugs. Functional purposes, laborers need, they don't need it, but they think so because most times they work better when they use cannabis, especially. So you find cannabis use being commoner among laborers. Functional as well, sexual performance is known to be better by those who abuse certain drugs, including heroin. And they think this is the only way to maintain their performance. Of course, one I've mentioned, psychiatric disorders, drugs might be the first solace an individual suffering from mental disorder gets, even before consulting anybody. If certain drugs are taken, one, the individual is confused. He doesn't even understand what is going on, what this is about. Doesn't even know it's an illness. I mean, just beginning to hear voices of people that you cannot see. And then you stumble upon either cigarette or cannabis or alcohol, something that reduces the voices. Then you think, oh, I think I need to use more of this thing to keep these voices away or to keep this sad mood or low feeling away. Of course, people who grow up in socially disadvantaged or educational disadvantaged environments are extremely prone to drug use. And then we also have peer pressure playing a role. Now, we know addiction is a brain disease that is chronic and relapsing in nature, unlike before when it was seen more as a moral failure, that you have failed morally, that is why you're addicted. And that this is a spiritual thing that needs to be beaten out of you or prayed out of you. Prayer is still important, but treatment is also extremely important these days. And why do people get addicted? The reward system in the brain plays a big role in this. The nucleus ambiguous, ventral tegmental area, dopamine production, when pleasant experiences are encountered, play a big role. And we have the natural rewards. which includes food, water, sex, and nurturing. When all these natural rewards are taken, the VT produces more dopamine, which gives you more pleasure and makes you want to experience those things again and again. When it's now drugs, that is where the problem is. If it's food, the dopamine output in experimental animals was shown to be just around 50 units of dopamine from the basal level. But when this same thing is measured for an activity such as sex, which is also a natural reward, you can have about 100 units of dopamine being produced. Unfortunately, when methamphetamine is used, over 1,000 units of dopamine will be produced, producing an incredible amount of pleasure. So when they say the pleasure is out of this world, it's actually an unthinkable amount of pleasure that is obtained from these substances that are not natural. They are not supposed to be used. So not starting at all is the rule for all of them, because the pleasure they produced, no amount of resistance you have as a human being, discipline you have, everything would dissolve in the presence of over 1,000 units of dopamine flooding your brain with so much pleasure. So that is why addiction develops. Unfortunately, the dose of drug that gives you these 1,000 units the first time will not give you 1,000 units the next time. It becomes less and less if you're using the same dose. Tolerance develops, so you begin to need higher doses of the same drugs. And of course, they are usually expensive. So that gives all the social consequences of drug use that we'll see down the line. So the rule is never to start. After repeated drug use, drug changes the brain, and we have evidence from SPECT, from PET that have been done over the years now showing that the normal brain and the brain of a drug user are functionally different. So you can see the direct impact of the drug on the brain. So when you're looking at metabolism, you see the difference. The brain on top is that of a normal person. Next is the cocaine abuser who has just started abstinence journey, 10 days of abstinence. And then when we look at the third layer, or third row, that is the brain of the cocaine abuser after 100 days of abstinence. You can see that the brightness is coming back into the picture. Most of the functional areas are picking up. It's also good news showing that if an individual abstains, say for 1 year, which is what we know now, most of the functions of the brain return back to normal. So recovery is possible. The brain regains its full functioning if abstinence can be maintained for a long enough period. Further evidence that it's a biological disorder once it's established. Now, I just need to go through a few slides of what is new. I mentioned earlier, psychedelic community is a major issue now in drug abuse and drug use, because psychedelics now are being researched for treatment of depression, PTSD. So there's a general more acceptance of the psychedelics. Those are the hallucinogens I mentioned earlier, LSD, magic mushroom, mescaline, and the rest of them. They are being used now in trying to moderate or treat some mental health conditions. So while the idea is not to increase substance use, but unfortunately, when you sort of conduct this sort of experiments, you are more or less validating the use of these drugs among young, impressionable minds in the community. Then there's also what is known as chemsex, which essentially is chemically induced improved sexual performance, as well as improved openness to trying weird sexual practices. This is known to be commoner amongst MSMs, men sleeping with men. and use several substances such as cocaine, GHB, drugs that generally dissolves your inhibition and makes you open to experiment. Of course, it comes with a lot of risk: HIV infection, mental and emotional effects, criminal risk, as well as substance addiction. Okay, I've mentioned about psychedelic communities and all that. The other thing is, while this is not news, it is topical at the moment because the number of deaths in the US continues to increase, over fourfold increase from about 2010 to 2022 from opioid overdose. And it's particularly important now because US, or the current government, is blaming Canada for most of the deaths occurring in US, that illegal fentanyl is coming in through Canada's borders, which of course is difficult to fathom because Canadians are also dying from the same condition. Drug overdose has increased in Canada more than twofold in the past few years as well. What else is new is the fact that there are 566 different new psychoactive substances on the global market. 5666, that's half of 1,000 different new psychoactive substances. And in 2022, 44 were newly identified. So when we look at this as an emerging epidemic and also look at the possibility of stopping it, it seems very slim because these new drugs, it will take a while before they're even classified as illegal substances, while it will have taken its toll on the population. There's also the emergence of in Africa of mixtures and concoctions with different substances in them. Examples include in Yelpe in South Africa, Kakubi in Morocco, Kush in Sierra Leone. Kakubi is said to be a mixture of, I think, cocaine, cheap psychotropic drugs, cannabis, alcohol, even glue are all used together in making the mixture. It's like a pill, and it's described as Rambo. It has a Rambo effect. It makes you feel superhuman, super powerful, hence it is used often to commit crimes. And then we have Kush in Sierra Leone, reputed to contain some human bones in the mixture, but essentially contains fentanyl, tramadol, formaldehyde, and then possible human bones from graves. While in Yelpe is reputed also, amongst other things, to contain antiretroviral drugs. What is new? Policy is another new area now that is making waves and causing issues or worth discussing. Currently, about 227 jurisdictions in the United States have enacted legal provisions allowing production and sale of cannabis for non-medical use. 27 jurisdictions. And this is in addition to countries like Canada, Uruguay, Netherlands, and several other countries that have also legalized or decriminalized the use of cannabis. But the interesting thing about policy is that there have also been some policy reversals more recently. So when we try to copy, we should be careful what we copy, as I will show in a few slides. There have been policy reversals in at least one jurisdiction in the US, and that is in Oregon. And they cited challenges to implementation, as well as lack of funding and limited drug service delivery as the reason they are reversing decriminalization of all drug use. Thailand as well, recently Professor Lashidikon called my attention to a publication in Thailand. They're also considering reversing the policy on decriminalizing or legitimizing recreational use of cannabis for a different reason. But the Oregon situation is particularly interesting. Oregon's budget for 2025 to 2027 is about $37 billion. There are just 4.2 million people in Oregon. Nigeria's budget for 2025 is $31 billion. Oregon is just a state in the US, but their budget is for 2 years, is $37.4 billion. Nigeria's budget for 2025 is $31 billion with a population of 227 million. Yet Oregon felt they do not have enough resources to accommodate decriminalizing use of drugs, because when you do that, there are so many other things you need to put in place. But they felt they don't have enough money for that. So for those who are pushing Nigeria diplomatically towards legalizing cannabis use, I think that story of Oregon is very instructive and might cause Nigerians to pause rather than go ahead. I once looked at the evidence in support of or against cannabis legitimate or decriminalization, so that decisions can be based on evidence available and all that. The story is that when you legalize, there's increased use among young people. There's increased attendance of emergencies among young people for cardiac mortality, cardiac morbidity issues, which was never known before legalization in some states in the US. And also there's increased incidence of both schizophrenia, bipolar, and other mental health challenges in both US and Canada, who in areas where they have been legalized. So we have all these challenges that comes with legalization. Legalization also is not like all bad news. No evidence has been found in women who have children of any malformation in the children or any negative impact on the children. But also what was expected when formulating policies for legalization is that the illegal cannabis world will crumble. Everybody will go to the legal place to buy, but that has not been supported also by evidence. The illegal cannabis market in California is still 4 times the size of the legal market, despite having legalized for more than a decade or so. So there's a few things that will not go as planned, and we need to learn from those jurisdictions that have done that before we take any action on legalization. Furthermore, our resources for treating drug use disorders are limited. Only 2.8% of people in Africa had access to treatment for drug use disorders. What are the consequences of drug abuse? Health consequences: mental health, physical health, disruption of family life, divorce, separation, loss of job, loss of status, destruction of academic career. Many young people have been removed from the possibility of getting a degree because of a positive drug test in our universities. I don't think that is right, but those are the rules of the universities and have to be followed. I think things could be done better, but the rules are the rules. If you go to a university that has such a rule and you are found to have a positive test, you will be let go, so to say. The exposure to crime and criminality, sudden death from overdose. I'll run through some of the consequences. I've mentioned mental health challenges, and these are the reasons why mental health issues develop in people who use drugs, or why mental health issues tend to occur with substance use. One, it could be a self-medication. One could lead to the other, and then sometimes the area of the brain that is affected could be responsible for both conditions. Trump did this declaration in his first tenure, and yet the emergency is still on, even now in this second tenure, with a 4-year interval in between. So drug issues are not an easily resolved or easily dealt with situation, and it's still ongoing. Of course, other consequences is the relationship with organized crime. There's a very strong nexus between drugs and crime, and that has been shown in different communities, including Nigeria, whereby most of the camps of terrorists and bandits that the military take over are usually filled with illegal substances being used in those places. This is just a slide to show how the complications could be really bad. This is a clean wound, but it didn't come in clean. It was really, really dirty wound from pentazocine dependence and injection into the muscle. Sometimes you have the whole muscle becoming fibrosed and movement becoming very difficult. Another pentazocine related consequence. And then we have tramadol and the rest. So is this a menace? Defined as something that threatens to cause evil, harm, injury, or a threat. Is drug abuse a menace? The answer is yes. It has all the qualities of being a threat, cause evil, can cause harm. But in engaging as health workers, it will be not advisable for us to treat it as a menace. We may have to use a more neutral term so that people can engage with those who are suffering from drug abuse, those who are addicted to drug abuse. If we go with the mindset of a menace, then engagement might be difficult. Could we have a drug-free world? That is also very unlikely. The profit from trading in drug is enormous, and it's almost impossible to completely prevent drug use. So what we can have is a controlled world of drug use and abuse. So what are the strategies to adopt to confront this problem? I've changed menace to problem. That is softer and less emotive term. Most important thing is prevention. Prevention is cheaper, is more likely to succeed than cure, than treatment, and every other activities that may come afterwards. So education and awareness is extremely important. And I think this is where CMDA can come in. We're having this from me as an expert to a group of doctors, but we need a step down to the community, which is something I believe CMDA is quite capable of doing. And you don't have to be a psychiatrist or a mental health expert to be able to convey this message to the community, to the schools, to the churches. Every church, you at least maybe once in a year or every 2 years, have a talk on substance abuse and substance dependence and addiction. It does not respect religious affiliation. Pastors, imams can get addicted. So we need the message in the churches where more young people would be. We also need it in the schools as well. And sometimes I do share my slides. This is a technical one, but the ones that can be used in public engagement, I have some that I can share with you that you can use in engaging the public. Healthy lifestyle is important. Exercise, having schools with sports ground for young people to sweat out rather than being isolated and bored and being tempted to use drugs is also important. All the other strategies are important as well, but nothing is as important as preventing people from getting into drugs. And education and awareness is one of the most important aspects. Of course, school-based programs are also extremely important. Community engagement, treatment and recovery. The federal government, no, the Senate passed a resolution that all teaching hospitals must have rehabilitation centers, blah, 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 but never backed up by resources, okay? So the recognition of the problem is there, and some political will is there, but hasn't been pushed to the point of implementation. Of course, the NDLA is doing a lot about this. They're going to equip 6 centers across the 6 geopolitical zones for rehabilitation, which that has been budgeted for and is ongoing. Mental health support is important. Recovery support, family involvement, rehabilitation for criminal offenders is also extremely important. Addressing substance abuse in the workplace is important, especially in the hospital. Many of our colleagues are currently suffering from pentazocine dependence, fentanyl dependence, but they don't feel confident enough to come forward to ask for help because they're afraid of what the system will do. And unfortunately, some systems in the hospitals tend to be punitive rather than supportive of engaging them and getting them to receive the help that they need to come out of the problem. So I know some of you are also in leadership position in the hospitals, kindly encourage our colleagues who may have these challenges to come forward and receive treatment, and also influence the management not to wade a big stick rather than being supportive. And that is where employee-assisted programs also come in. This is very effective in private organizations, but not public institutions tend not to have adopted that part of human resource management. It's a very important aspect of human resource management. Of course, training and education is important for supervisors and managers. And let me conclude with take-home messages as we round up. One, drug abuse is a global epidemic of public health concern. So it is not a uniquely Nigerian problem, but it's an important problem to Nigeria because we do not have the resources to cope with the epidemic that is already upon us, which might be made worse if political decisions are currently taken, such as legalizing the use of cannabis or use of any drug for that matter. The impact of the epidemic is due to is bound to be made worse, I said, by poor access, and then policy decisions with regard to legalization or decriminalization should be evidence-based and should also take into consideration the resources available for the country for implementation. And finally, prevention is at the core of curbing the problem, and we need to all individually and as a group in CMDA be involved in propagating the message of preventing young people from commencing the journey of drug abuse. Thank you very much for your attention.
Thank you very much, sir, for such a wonderful presentation. It's very eye-opening. We had a summary of what is currently ongoing, and I want to thank our guest speaker for such a wonderful presentation. I want to know if we have questions, but I would first of all look at the chat. If there are questions for him to take, he will take them directly. And then I would also want to encourage every one of us to drop our questions and comments. Indeed, my own thought right now is that is a problem, and I've taken that away rather than a menace, so that I can reach out to not just my colleague that could have some of this addictive behavior or are addicted to any substance, or even those who are around us, because we see this every now and then, and the school, the church, and all of that. And so I will be coming for a material myself for my church, and I would see that we can all do that for our churches and our community. So thank you so much, sir. I would look at the chat and see if we can take any of the questions.
Dr. Eseli, we have a hand up. I think we can also entertain.
Oh, okay. Yes. Please, you can unmute and go ahead to ask a question. Oh, Dr. Sojimi, good to have you. Please go ahead, sir. Sir, Vice Chair.
Good evening, everyone. Thank you, Dr. Victor Makanjuola, for the brilliant presentation. I also appreciate the organizers of this program, especially my people in CMDA Oyo. I'm very happy, especially for the attendance, very good attendance. Just to support the speaker, I was in Kenya early this year for a pain camp sponsored by International Association for the Study of Pain. In that program, cannabis is presented as a potent analgesic and antiemetic. It is being prescribed like other narcotics in US and Canada. The speaker also talk about this. But my concern is this drug abuse in our community. Cannabis is even more popular than cigarette smoking among our youth. So as Christian doctors, So how can we take evangelism or medical outreach to these people? If the Christian mental physician taking the lead, I know that Dr. Peter Bakajola will be happy to lead us in this assignment. Then the second question is that of the usual thing that people used to say, that a little alcohol. People will even quote the Bible that a little alcohol is good for your health. That Apostle Paul told Timothy. So what is your take on this, especially from your experience when you see patients coming to your clinic? So when you take history, is there any link between a little alcohol intake and their psychiatric problem? Thank you once again. God bless you.
Thank you very much, sir. Let me quickly respond to that. And thank you for your kind words as well. I think the evangelism is long overdue. It's been ongoing. I'm aware of several churches who have had programs along educating people about drug abuse and what the young people need to look out for. And even at that program, some young people will come up and say, oh, I'm actually facing this challenge at this point. My classmates gave me something to take for headache, and I can't stop using it since that day. I've been buying it. I don't even know what the name is. So sometimes we even get people right there. The interventions have to be done for and come out of the problem. And that's why I'm encouraging all of us as well to go out and not feel limited that because I'm not a mental health expert, I can't talk about drug abuse. No, I think every doctor should be able to do that. The problem, secondly, is about United States and the developed world. It's like people not learning from their mistakes. The opioid crisis currently in the US did not start because young people just got adventurous and were looking for opioids. It started when the US liberalized prescription of analgesics, opioid analgesics. They were so liberal about it that a patient could report you as a doctor if you fail to prescribe opioid for his pain, which most times are not even pains that required opioids. Yes, terminal cancers, terminal conditions, really chronic painful conditions require opioid analgesia, and people should be given when they're in that situation. But I have a leg, I bang my leg, you give me pentazocine, I sport injury, you give me fentanyl or whatever. It's an abuse of opioids. And it started in the US. Unfortunately, they are the ones also reaping the consequences. Unfortunately, don't let me be mean to them. Unfortunately, they are the ones reaping the consequences the most. But you still have groups from the same country going outside and encouraging more liberal prescription in other countries. My take is don't take their advice. It's good to have opiates for pain relief, but don't be liberal with the prescription as they have done and has caused this consequence. There was because they prescribed liberally in the clinics, people got to know about the feel-good effects, and that trickled somewhat into the general population, and then illegal production started. And I mean, people have died, including Michael Jackson and all that, from this sort of activities in the US. So I don't think we as a group or a people should take whatever they bring in hook, line, and sinker and start prescribing the way they have. We just don't have the resources they have in dealing with the problem. And with all their resources, towns are still being wiped out by opioid overdose in the US, where you have only 2 generations of people now, children and grandparents. All the parents have practically died off from overdose of opioids. Either they are dead or they are living dead because they are unproductive. So is a place where we don't want to go as a country. Alcohol is it's a social drug. It's acceptable use in many places, in many situations. but it's also a very dangerous drug if you are vulnerable to its negative effects. And there is no way to know whether you're vulnerable or not. So I always advise, if you have not started, don't. If you have started, you will know by now whether you are vulnerable to its negative effects or not. I've seen someone who drank only in his life for just about 5 to 7 years, and he died. And we have seen people who have drank alcohol all their lives and they're in their 90s. So there's some sort of genetic vulnerability to the problems of alcohol, which you may not know if you don't have a good understanding of your family history. In fact, that history is often hidden from you as an individual, because no one will tell you that your uncle died of alcohol-related problem or your father died of alcohol-related problem. So you may not be, that may not be available to you. But alcohol use can be really, really dangerous in those who are genetically vulnerable to its negative effects, and could result in death in a very short pace of time, 5, 7 years. Some can die from alcohol. So it's better not to start, just like every other drug. Thank you, sir.
Thank you so much, sir. We still have Sister Dr. Olani George. Your hands is raised. Please, you can ask your question, ma.
Okay, thank you very much, sir. I was already typing. Thank you, Dr. Makanjola, for the wonderful lecture. Again, it's obviously a can't miss lecture. So I have a few comments and also some questions, sir. First of all, I want to say that the prevention policy that you mentioned needs actually to be on ground in our facilities, and I mean in our health facilities, as much as in our communities. And this is because, like you mentioned, we have several colleagues, time and again falling victim of this. So we need to make awareness available in our facilities as well, not assuming that everybody knows that they shouldn't take these things, but in our communities. Then are we leveraging sufficiently on social media? Because if you want the message to get out, we need to go to where the hearers, the public actually resides. And the truth of the matter is that the generation that we're trying to reach lives and breathes social media. So we need to leverage on social media as a veritable tool, to reach them. Then a question I have is, how can we balance, the very real problem of chronic pain and the fear of addiction, and also having at the back of our mind the need for a decent quality of life. And I manage a number of people with chronic pain, some HPSS, some various musculoskeletal conditions that are chronic, and they just want to feel well. They just want to feel relieved. They just want to feel like the next person. Even it gets to a stage where you withholding these medications from them somehow seems cruel. So how do we balance that? Then another question is, we have a dearth of facilities that are available for detoxification. And even those that are available are expensive for the man in the street. So what do we do? I personally own a facility, but at the end of the day, I'm wondering, is it possible? I get a lot of requests for people to come in and have detoxification. But when you think of the time, when you think of the cost, when you think of the personnel that is required, of course, there has to be a psychiatrist, in attendance. So can you please speak to the minimum standard for a facility that can admit for treatment of substance abuse disorders? And finally, is there any punishment? Are we really speaking from both sides of the mouth, or we're just speaking to the gallery when we're talking about prevention? Because the supply chain is not affected. I dare say that the drug problem, even in Nigeria, is being micromanaged by a cabal. Can they be unveiled, or do we just go to God in prayer? Thank you so much.
Thank you very much, man. I don't think we need to give up. Of course, we need to keep praying, for for the problem to be significantly reduced. So we still need to pray, but not because there's nothing else we can do. In terms of supply, NDLA has been really proactive in the past 5 years thereabout. You know, thereabout. They are actually making a lot of seizures. They are breaking the supply chains here and there. But like I showed about how lucrative the market is, people, do you know people take drugs to countries where they know that the penalty in that country is death? 2 people were still arrested by NDLA taking drugs to Saudi Arabia, of all places, where it's almost like immediate. Once you are found with that, you go to court, you're sentenced to death, you get hanged as quickly as possible. So it's obvious that it's death penalty, but because of the greed and the allure of making such humongous profit, the trade will still persist, irrespective of what we do. But we must acknowledge the fact that the supply chain is not as free flowing as it was about 10 years ago, when the NDLA was completely prostrate. And that is also an issue of governance that came up in one of the slides. When drug use prevails in a country, it will creep into your governance. And the Senate of that time practically crippled the organization by not allocating resources to them until the next government came and appointed the current chairman of the organization, who seems to enjoy good patronage of the president, the past one and the current one. So he's getting a lot of resources to fight the menace. So that is ongoing. The challenge in the hospital, I I think we need, in terms of trying to balance when it comes to pain management, I think the challenge is not so much with people with chronic pain. We already know chronic severe pain that is going to be there for a long time. We already know they need something extra. They are not going to be our NSAID and paracetamol kind of pain management. And they are not usually the ones who run into problems. They're not always the ones. Yes, we have people with sickle cell disease as a major group that are at risk, because it's going to be a lifelong issue, and you may need to titrate between opiates and other drugs in their management, and be vigilant to know when the request for pain relief is really for pain relief and not because they're already getting addicted to the substance. We've had people on admission, HBS, but the team, hematology, has recognized that they are dependent, and that is how they get to us. And then they're on admission, and after some time of interacting with them, and we ask them, are you sure there's pain? And then they smile and say, really, doc, there's no pain, but I need this thing, I won't sleep. So we start, the moment, if you get very close to the patient, it takes time to achieve this. They will open up and let you know that the demand for analgesia sometimes is not for pain. And that is how we overcome, the disorder in some of the patients. I haven't been with them over time and been able to identify when is real pain, when is not real pain. But of course, if they're presenting a non-specialist center, the assumption is that they have the pain and they will get the shots. But I think now you should sort of be quite vigilant and probe more. And I'm not sure you will be qualified or licensed to do what some of our nurses do under supervision when we have such a patient, and they give placebo. The pain also disappears. Physiological pain will not disappear if you are not giving analgesia. So we tend to know from that their pain is entirely, or at least mostly, psychological. So sometimes, oh, I'm in pain, then water for injection is given instead of analgesia, and they sleep soundly afterwards. So that sometimes helps us to distinguish someone with real pain and someone who is already dependent on the drug and is having more of psychological dependence rather than physical pain at the time. But I agree that we are not going to say no to opiates for someone with chronic pain, but for someone with any other form of pain, I think it's wise to go slow and avoid opiates for as long as it is possible, because it's almost like a downward trend once dependence is established. And you, as the doctor prescribing the opiate at that point, will not know when that person is going down, because they stop coming to you for next prescriptions. They know you're going to be suspicious, so they go elsewhere for subsequent prescriptions, and then they end up on our service. Thank you for the earlier comments. They're perfect. Social media engagement and the other comments you made earlier, they are extremely important. Those are very coming from very deep thoughts, and being, you know, a public health primary care person that you are, that those things are extremely important for us to adopt. Thank you, ma'am.
Thank you so much, sir. I think there was a mention of what would be required to have a place that some people can come in for detoxification. I don't know if you want to speak to that. That's the one of the
Yes,
questions that we raised.
the detoxification is serious business. What is easier to do is rehabilitation after detoxification. Uh, People tend to set up rehabilitation centers, and they bring in patients fresh, which is very dangerous thing to do, because withdrawal symptoms can be life-threatening, and they are better done in hospitals where you could have access to even ventilation if it's necessary, you know, taking over the person's respiratory functions if necessary. So I think for detox, for someone who is actively using drugs, the detox, at least the first 2 weeks, should be spent in an hospital that have the capacity to deal with that. But for people who have been on and off, they're not currently actively using, but they need to be taken off. They need a longer period, or they've gone through detox in an hospital. Then rehabilitation centers, such as the ones she mentioned, can be quite useful. And there are also training programs going on to sort of standardize the care that is given in rehabilitation centers. Federal Neuropsychiatric Hospital Yaba, Dr. Jumoke seems to be doing a lot of training in that regard. And we also have ISOP in Oyo State that could also, I think they're planning to host a training soon, which you could also be part of. ISOP is a society of you know, people working in drug abuse. That is a great thing that has come up, and such platform can conduct or host trainings for other people that want to run a rehabilitation center. There are a few rehabilitation centers in the Badon, and it's extremely important that psychiatric cover for those centers, because comorbidity of substance addiction and psychiatric disorders is so common. It's so common, such that treatment is incomplete when you don't have a psychiatrist involved, but not necessarily residents in those facilities. There are several other things in rehabilitation that does not require the physical presence of the psychiatrist, but you need to have one that at least you can call for assessment and for treatment planning. Thank you very much.
Thank you, sir. I would ask Dr. Adebite, are there questions, other questions you want to quickly ask? Then we can then for Dr. Ngelato to round up.
Thank you very much, sir. There are a couple of questions in the chat box here. We have this coming from Brother Hege, saying he has a colleague in anesthesiology who has been in rehab for close to 3 months. So he would like to know what can be done to prevent drug abuse among colleagues, beyond advocating that they should not be punished by our health institutions. Also,
well, I think education is the first thing. We assume because we all went through medical school, we know the dangers of drug abuse, but that is not true. depending on which institution you train, the exposure to mental health could be as little as 4 weeks, during which period you may not really get to see the damage or the danger of addiction. And then you become a doctor, you are oblivious of the so sessions like these could be helpful if a doctor attends, and several other places where issues. By June 26, all the airways will be filled with talks about addiction, being the World Drug Abuse Day, World Drug Day, so to say. So doctors could benefit from such advocacy as well. But it's I think we need also to now focus on at-risk populations. Even within medicine, there's an at-risk population, and that is anesthesiology. It's a subspecialty that is very much at risk. I'll probably put psychiatry at risk as well, because we have knowledge about those substances and what they can do. And even access is also easier for us because our clients or our patients have access to the drugs as well. So that your patient does not become your supplier. So psychiatry and anesthesiologists are at-risk groups in medicine. Same as surgeons as well, because they also have whatever the anesthesiologist has access to, they also have some access to. So we need to do targeted education and awareness for this group of doctors. And also, beyond, you said beyond, but it's extremely important to have that component of non-punitive interventions when people have already crossed the line and they're already addicted to a substance, either at the early phase or later phase. That non-punitive clause is what will make people to come into treatment and escape the possibility of dying from the disorder. Thank you very much.
Thank you, sir. This one is coming
from... Sorry, Dr. David, sorry, because of our time constraint, can we take all the questions together so that our speaker can attend? Yeah, thank you.
All right, sir. So this one is coming from Baba Okidare, chairman, CMDA Oyo. He would like to know the best way to take to prevent the young ones from starting the journey of drug abuse.
Education. Basically, that's what we can do. And I think the other thing that could be done.
I think, sir, I think we would like to take all the questions so that I can note them, then you can address them, because there might be repetition in some of those questions.
Yeah.
Yes, sir. So the next question I have here is coming from Brother Odedino. It said, concerning shift in policy towards decriminalization and outright legalization, how can we lobby to prevent this move or push for counter policies to make sure this does not happen in our country? This one is coming from Brother Femi Adewi. It says countries like Canada are focusing on safe supply and harm reduction rather than therapy and prevention. So they say it is evidence-based and scientific. So you would like to know your opinion on this? And do you think it is more political or really medically sound, even though these same countries have more drug-related deaths? We have this one coming from Sister Jemima. Says, thank you so much for this presentation. Knowing that running rehabilitation program for drugs can be very demanding and expensive, is there any recommendation on how to start small in a community bedeviled by this plague? What are those things she can do to help the young ones, apart from holding programs, to educate them on the illicit use of drugs and its impacts? Also, we have this one from Shuretire
Camille.
Shuretire
Camille. Yeah.
Thank you, sir. Said we have a mental health policy 2023. How are we leveraging on this to push for the needed support for prevention and rehabilitation? We have, I think that is the last question that we have in the chat box, sir.
Okay, thank you very much. I'll start with the preventing young ones from going into this? What else can we do? It's always about education. The young mind is impressionable, and the earlier you reach them before the counterparts, people with negative intent reach them, the better. And that means drug educations to start as early as primary school. If the first time you're hearing about drugs in secondary school is probably too late. Age of onset of use of alcohol and most drugs is around 12 years old, which is from 1, from 2, thereabout in Nigeria. That's the age of onset of tobacco smoking, alcohol use and all that. Is around that range of 12 to 14, 12 to 15. So you need to reach them before there's exposure to these drugs, and that is from primary school. And I think the curriculum has a bit of that in primary schools, just that to ensure that these things are taught as they should be, and there are special programs as well to promote, ability to resist drugs, assertiveness when you're invited by peers to say no, how to say no to drug without your peers, mounting another comeback and trying to push you towards it. So education is the most important thing, and it has to go through the school system. That we reach more people than every other activity that we're trying to do, which is important. We still need to do those ones through churches, through camps, and the rest that we have. But through the school system will be a more direct way of reaching as many young people as possible, which also comes to the issue of legalization and the example of Canada telling us about, evidence-based process and what we're doing and all that and all that. They are right that there's evidence for harm reduction, which is great. But do we have resources for harm reduction in Nigeria? That is the question. Harm reduction involves sometimes for injecting drug users, placing syringes in strategic places for drug users to pick to use for the injection, so that they don't use needles that are being used by other people. We have a country where patients have to go and buy, people in need have to go and buy their own syringes, even when they have paid for treatment in hospitals. We have situations where gloves are being reused in the country out of poverty, not because the health workers don't know they're not supposed to reuse. We have all these existential problems. Do we have the resources to start placing syringe in strategic places for drug users? I don't think so. Prioritization, like I said, education is the best thing, and it has to go through the school system. How many out of school children do we have in Nigeria? So we're going to lock out all those people if drug education comes through the education system. So we need to get more of those people into the education system. I think those should be Nigeria's priorities, not placing of syringes in strategic places, not organizing raids for drug addicts to, bring them out and get them engaged in harm reduction strategies. So these things that are presented as evidence-based, they are evidence-based for the context where they exist, not for Nigeria's situation. So you cannot just take an idea and transpose it onto the country with our current challenges and think that those things are exactly what we need at this point in time. So that is my concern with what Canada says about drug use and NAB. And of course, like you mentioned, they have more of the challenges with drug use, and we have families who have had to repatriate their children from the country because of their laissez-faire attitude towards drug use, and a young man has gone psychotic and not receiving treatment. So they have all those challenges that we don't want to copy. But as a scientist, go more with evidence. I don't think there is something mortally wrong with legalizing cannabis use or any drug for that matter. But I'm also a Nigerian. Probably if I'm a Canadian, I might also be pushing that you should do it, since I won't be the one suffering the consequences. But as a Nigerian, I'm also looking at, do we have enough evidence to support legalizing cannabis use with minimal consequences on the Nigerian populace? Currently, the evidence does not support that. And like I mentioned, even states that have started in the US are reversing the policy. Thailand as a country is also reversing the policy based on the experience of the consequences of legalizing. While Oregon's zone is based on realization of how much resources is required to implement the next steps after you legalize. And this is a country, Nigeria, that the resources we have, I think, should be devoted to out-of-school children getting to schools. It should be devoted to eradicating abject poverty. Those are two main things that if we are not addressing that, talking about drug abuse and the rest is esoteric. Okay, so it's in terms of prioritization. Now getting a group to argue against that in parliament and all that may not be in my jurisdiction as a scientist, because I'm open to both ways. Whatever happens, I'll study and I'll publish, okay? But I think groups that have the passion and then I can provide them with the evidence and they can go ahead and advocate against doing this at this point. I'm also aware that the chairman of NDLEA is also not pro legalization, which is probably the only thing standing between legalizing it in Nigeria now. The chairman is not pro legalization, is publicly anti legalization, but there's a lot of pressure from, you know, the usual places outside the country for us to legalize. So a group, even if CMDA takes it up, that would be great. Evidence will be provided to help you argue on the floor of the Senate and the House of Rep against legalization. It's also important to engage with democratic process actively. Laws are going to be made that will affect our lives of our children if we are not proactive. So if CMDA does not have a political arm, so to say, that is ready to go for every public hearing when it comes to matters that are important to us as Christians or important to us as doctors, then that should start happening. You should develop that harm that when announcements are made for public hearing on, say, legalization of cannabis, that group should be, everybody is welcome, but that group should be there also to marshal points against that the position. And that I will encourage, and it's extremely important that we do that as Christians and not keep quiet and allow things to continue the way it is. Rehabilitation, starting small, could be done. It could be done with a few rooms, with even one or two clients. One can start small and grow. But the issue about rehabilitation is time consuming, is resources consuming. Professor, Dr. George mentioned that it's a lot of money to stay in rehab because you are not working while you're in rehab and you're going to be eating and getting entertained one way or the other, getting occupied with some activities. Somebody has to be paying for that luxury. That is why, despite the fact that there are few rehabs, uptake is still even fewer than available facilities. So they are not like busting at the seams. If you see a rehab that is busting at the seams, it's probably very cheap or public facility. So I think government needs to invest more in public rehabilitation that will be easier to afford, but not of less quality than the private ones that we have as well. But one can start really small. It doesn't have to be something big. While one continues to engage with young people about the dangers of the use of substances. Now, when we do this, most of the time, we talk to them the thing we need to do more is to listen to them. The reason why they are tempted, the reason why they're using is what we need to listen to and address. If their parents are always fighting and the only way this young person gets some sleep is to use cannabis, the issue is not that cannabis use, is to address the issue of the parents that are always fighting. Okay, so you can see that most times what we see in the children, it's a symptom, but the real illness is in the family. So we need to have this sort of family therapies that are going to reduce the symptom that we're seeing in the young person or in the young child. So that's another very important part of interventions that we might think of. Dr. Shoretire's comment is also extremely important, that we use available policy to leverage on the mental health policy 2023. I think the first one was 1991, and we're lucky that it's been updated. I think this is about the second update, and we need to use that to push for prevention and rehabilitation resources for the country. I also mentioned I think people in charge of facilities or government establishments like teaching hospitals, other hospitals, FMCs, may not be making enough effort, or probably they don't consider rehabilitation as a major issue. There's a document from the Senate that mandated all hospitals to have a rehabilitation center. In preparing a budget for the next year, that document could be attached for a budget provision in let's say my hospital, for a rehabilitation center. And I mean, since it's coming from those people, I'm sure defending it in the Senate or the House of Rep will be a lot easier, since the mandate, the resolution is coming from them as well. But most of the times we don't engage with the democratic process as well as we should. Those of us on the either in the civil service, I think civil service is even sometimes better, but the managers of facilities sometimes don't engage as actively as they should in this process. The mental health policy is another tool that can be used to justify a budgetary, preparing a budget for one's facility to have a purpose-built rehabilitation center. And I know of some centers up north that have made this provision already, and they're going to have really massive rehabilitation centers provided by the Nigerian government. Once you use the tools that are available, such as mental health policy, resolution of the Senate, of the National Assembly, and other important documents that come from different agencies to make a case. The Nigerian government is more receptive than we think they are to ideas coming from organizations and also from what do we call them now? MDAs, the different agencies of government. Thank you very much, Dr. Shoretile, for bringing that up. Thank you once again, everyone, for listening.
Thank you very much, Dr. Makanjuola, for taking out of your busy schedule to give us this enlightening lecture. We all know that drug abuse is really a global concern among the youths who are the leaders of tomorrow. And I want to especially appreciate you for providing all those insights into the strategies that can be used to address these challenges. Once again, thank you very much, and God bless you, real good, sir.
Thank you very much. Thank you for having me.
Thank you very much, sir. We are blessed to have the presence of our leaders and fathers in this business of caring for the whole man, spirit, soul, and body. So I would like to call on Dr. Ngalato to acknowledge the presence of our leaders in this meeting.
Oh, all right. Thank you so very much. Thank you, Dr. Adegbite, for a wonderful moderation. Thank you so much, Dr. Makanjuola. It was just too much to handle. It was so enlightening. We are very grateful. We look forward to unbundling more of this at subsequent webinars. Thank you so much, sir. Without much waste of our time, I'd like to appreciate and also acknowledge some of our leaders, members of the Board of Governors who are currently with us on this call. Our immediate past president, Dr. Kayode Iyun, is with us. Thank you so much, sir. Our deputy CEO, Dr. Ege Aye, is also with us. We are very grateful. Thank you, sir. The VP West, Dr. Olateju, is also with us. We are so grateful and thank you for being there with us. Thank you. The VP West, VP East, Dr. Ogonna, is also here with us. And before I round up the call and also invite the person to take the closing prayer, I also want to appreciate also the chairman committee on the CPD board, Professor Femi Ogundipe. I don't know if you would have a word or two before the call is ended. Thank you so much, everyone, for making it for today's webinar. So I want to welcome Professor Ogundipe. Yes, sir.
Judging by the comments and the feedback from participants at this call, it's obvious that Dr. Makanjuola's presentation is very, very, very well received. And that's being said, I will Zuma Gimba to appreciate you sincerely. My set leader in mentioned 4 take-home points. I want to assure you that the board committee on CPD of CMDA has taken note need for context-specific policies that you mentioned. And I want to crave your indulgence that the board committee of CMDA will be reaching out shortly, because we are in the process of developing policy briefs and also collect data that will inform our policy briefs. Thank you very much once again. With that said, I want to thank all the participants for staying till now, and to also invite you to next month's monthly webinar. Thank you very much. And
all right, thank you so much.
Thank you very much,
sir. All right, thank you so much, sir. So Dr. Adegbite, you can, I think we can call off the last closing prayer.
Sorry, I don't think, okay. Dr. Adegbite. Okay, I would want to invite our chairman or your state branch CMDA, Dr. Okedare, to take the closing prayer. Just before that, if you have any comments, we'll make it, and then it was the closing prayer. Thank you very much, everyone. It's been a wonderful time today.
It's with a lot of joy and appreciation to God Almighty and to all our planners of this particular webinar, as well as our very erudite facilitator who has done justice to this topic. I know that all of us are excited that we are equipped now, not only to know the problem, but also to see some of the ways by which we can start to work towards not only policy, or even some of the little ways we can start to prevent this serious epidemic that is coming up. Thank you once again, everyone. Shall we pray? Father in heaven, we are so grateful that you gave us this day and you have made all the effort and all the planning for this webinar to be successful. You have also helped us that all the presentation and execution of the program has been very enlightening, very educative, and indeed a great blessing to our knowledge and to us, not only as CMDA Oyo, but nationally, as well as to all of us in the various institutions that we are. Father, with all of this great weapon of strategy that you are giving us, we are praying for grace to move forward, that not only in our community, but in our nation at large, this great problem will be solved, will be curbed, and your grace and peace will rest not only on us, but even on our youth and our children and grandchildren that are coming up. That drug abuse and other vices, by your might and power, will be reduced in our land. Peace and prosperity will continue to be our experience as a nation. Lord, as you have promised, you will restore us as a nation. As your word has prophesied, and as we have taken it, that yes, you will restore the years that the cankerworm have eaten, the caterpillar and the palmerworm. Lord, let the years of grace and mercy, the great years of abundance, continue to return to our land. Thank you, Heavenly Father. We pray for blessing and more grace upon our speaker, and more even upon all of us, that we will continue to make impact in every area where you have planted us, fulfilling our purpose. Thank you, Holy Spirit. For CMDA Nigeria, continue to strengthen us and take us to greater height. Thank you, our Father. In Jesus' mighty name, we have prayed. Amen, and amen.
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 Good evening, everyone. Do have a nice week.